is getting crazy. COVID is getting crazy. And I've been working with Dr. Harville now for probably close to a year on autoimmunity and some of the atypical patients that we see in the neurodiversity clinic. And he's actually been gracious enough to come over as a visiting professor on Wednesday afternoons to see patients with me. And we've seen a collection of different autoimmune encephalopathies and disorders. And with the recognition that long haul COVID is coming our way, if you know, the two major complaints that patients post-COVID have are fatigue and brain fog. And if you just included the question of, and what's your mood been like, you're probably going to see a lot of people that are going to score significantly on the PHQ-9, and they're going to come our way. So it's a little bit different. I think Dr. Harville has a different take on things that would benefit us as psychiatrists to really understand. So Dr. Harville, as you can see, has all kinds of credentials. One of the credentials that's not listed on that face sheet is he's actually a hypnotist as well. So he speaks our language, okay? So without anything else, Dr. Harville, please educate us.
Thanks for Jeff, and again, I'd like to thank you for reaching out for this kind of invitation. And as mentioned, because of the way things are discussed, that sometimes items can be lost or misunderstood. And I want to make sure that these things are clarified. And so I have some disclaimers you can be reading through. So if there's something that comes up during the discussion that just doesn't seem to be right from what you've read or heard from others, let's clarify it right then so that it doesn't continue to be misunderstood or going the wrong direction. So again, please ask. Time, you know, how many hours do you guys want to spend? Well, we could talk about this for quite a long time. And so I have to limit the issues to some things that I think they're critical. And I'll go over those in a second. And as mentioned, I have no financial or fiduciary interest in any of the things I'll be discussing. And for this presentation, what I'm going to do is go through a brief discussion of the genes that are involved in autoimmunity, immunodeficiency, the role of the HLA system, how T lymphocytes develop with the signal transduction, B lymphocytes with signal transduction, how immune regulation is present to try to prevent autoimmunity, issues of quality control failure that lead to autoimmunity. Then I'm going to summarize this part, which is more of the specific immune responses, and then go into what happens before you have these specific responses. And so we'll talk about what's going on with chemokines. I'll explain what those are, the inflammatory processes that result in activation of immunity. And then I'm going to present some data on an N of 1 patient that has neuroinflammatory disease who presented with psychiatric symptoms. I'm also going to give some data that hasn't been published yet that was generated looking at COVID-19 and the prolonged inflammatory disease associated with it. And then we'll have some final conclusions at the end. And as always, as you guys recognize dealing with the brain, things are always more complicated than what we'd want. And every day it gets more complicated. And so what has happened, though, is over the last 20 years, we have now been finding genes that are involved in the normal activation and regulation of immunity, that specific mutations can result in immune deficiency or autoimmunity or both in the same people. And so the old sort of paradigm we had of autoimmunity being high immunity and immune deficiency being low immunity, the genes aren't there. The genes are the same. And so it's the way these things are being influenced by environmental factors and other pathways is going to result in the final clinical product that we see from there. And subtle changes in pathways may have profound downstream effects. And we frequently don't think about the fact that something initiates a process at one point, and then there are multiple steps until you get to the finished product. And changes at the beginning can have profound adverse events or problems at the end. And another thing that people don't recognize, because we always promote how wonderful the immune system is the adaptive type of immune system. So T lymphocytes are getting activated up, doesn't want to activate up. It takes quite a bit of effort to overcome the barriers to actually initiate an immune response and activation of immunity. And so here's about the genes, and I'm going to quiz you at the end. So might take a screenshot so you can get them. Obviously, just kidding. The gene is listed on the first column, primary immunodeficiency associated with it, and the second, and on the right-hand side are specific autoimmunities that are associated with those genes. And what you will notice is that there are many of them affect the hematologic system and gastrointestinal system, and that this is seen over and over again. And so what's important about that is that the person with immune deficiency may be presenting to the gastroenterologist because of inflammatory bowel disease and not get the correct diagnosis. When we think about the genes involved, if we look at a genome-wide array association, it turns out the HLA locus is the most relevant for this, and HLA is near and dear to my heart. And as you can see there in the chromosome 6, the short arm, that it goes off the scale compared to all other loci in the human genome. And so HLA is always playing an important role in any form of immune activation and autoimmunity. So some things to think about when we're thinking about HLA and autoimmunity is that from the smallest microorganisms to the largest, we're all made of the same proteins. And in many cases, the protein sequences are conserved across multiple organisms. And so these proteins will be digested up by the antigen-presenting cells to be presented in HLA class 2 as usually 12 to 16 amino acids in length, and for class 1 and 8 amino acids in length. And so exogenous peptides that are being picked up are going into class 2, but the endogenous peptides are going into class 1. And those are peptides where the body is surveilling its own cells for whether there might be an infection present or cancer present. That is where you're having abnormal peptides being presented in the HLA. And so therefore there has to be a careful discrimination for what's going on here so that we can tell what's really us and what's not us. And so when you read the textbooks, you'll read about how that we think of some autoimmunity occurring because of foreign peptide with very similar features to self-peptide. And the T lymphocytes start cross-reacting and the infection doesn't go away. So an example of this might be rheumatic fever, where the components of the heart valves and our connective tissue are very similar to in structure to some of the ones from streptococcal bacteria. And the immune system doesn't know when to shut off because the infection doesn't go away, so it just keeps going and going and going.
Dr. Harville, we have a question in the chat. Could you?
Yes.
The question was, what does conserved mean in that context? And does that mean conserved from an evolutionary perspective?
Yes. And so once evolution has decided what is a correct structure that has a very high relevance, then those proteins, amino acid structures remain the same. So for example, cytochrome C from a yeast is almost identical in its sequence to that of a human being. And it's so important that it can't be changed without losing its function.
Thank you.
So going forward here, that the T lymphocytes that would have potential self-reactivity are supposed to be eliminated. And so I'll show you how this occurs in a few moments. But more than 95% of all our developing T lymphocytes are lost because they either can't bind HLA appropriately, or they bind so too tightly that they would react with self-antigen and result in autoimmune disease. And to help going further with this, that the HLA molecule are very highly polymorphic. There are more than 20,000 different sequences known for the HLA molecules in humans. I note to people that we know all the families of HLA that are there until the aliens land, and then we'll have to reclassify things. But depending on the HLA type and the TCRs that have been adapted to that through selection processes, the presentation of a peptide in a certain orientation may mimic the self-peptide, and such that you start the autoimmune process. Whereas if the peptide's in a different orientation, it would not elicit that response. And I'll illustrate that. And so here's an HLA molecule, and the pinkish color is the or the alpha helices sitting on a beta-pleated sheet, and the green is an antigen sitting in the binding groove. In this case, the R group, denoted by the arrow and the silver bar, is sitting in a certain orientation that would never interact with a T cell in a manner to cause disease. Whereas if you inherit certain HLA types, and I'll mention this further in a moment, that the presentation of a specific peptide in the orientation may elicit disease. For example, most of you probably have heard of HLA-B27 and ankylosing spondylitis. Well, it turns out there's a peptide from Klebsiella that fits into the binding groove that seems to be the eliciting process for generating the spondyloarthropathy type diseases. And so if you don't have B27 related components, this peptide never sits in orientation to activate the T lymphocytes that result in the spondyloarthropathy type diseases. And so speaking of that, these are the HLA types that are associated with the spondyloarthropathies. And people will say between 7 Craig, but the correct term is B7 Craig. And this will include such things as ankylosing spondylitis, inflammatory bowel disease, Crohn's disease, psoriasis, and uveitis. And other things that I haven't mentioned there that get lumped into other things, for example, Reiter's syndrome, where you'd have the sacroiliitis and the urethritis. And so all of these are post-infectious type of inflammatory processes that certain microorganisms seem to trigger. Another one is DR4, and that's associated with development of rheumatoid arthritis. Also, when you have post-surgical immunodeficiency disease, such as rheumatic fever. And so once again, excuse me, we have the possibility of microorganisms that are being presented in the HLA molecule that are interacting with specific T lymphocytes that are resulting in the disease process. Another example would be the A1B8DR3 with C4 null allele that's associated with small vessel vasculitis, including such things as lupus, MCTD, and dermatomyositis and scleroderma. And so in my rheumatology practice, I frequently look for the HLA molecules to try to determine whether or not someone was at risk, and to see if we could do something before they came down with horrible disease. So who develops autoimmunity? Well, it's the people that inherited the genes of susceptibility, like some of the ones I showed you earlier. And then there's some kind of environmental factor that promotes the process. So an infection occurring, or it could be certain chemicals that are found in the environment or someone comes in contact with. Irradiation may be playing a role. UV light can be playing a role in certain circumstances. And so now the objectives. So I gave you some background. And so we're going to go over what happens with normal T lymphocyte and B lymphocyte development and how things seem to go wrong with that to result in autoimmunity. We're going to talk about the homeostatic balances that are present trying to prevent autoimmunity, and how when these balances go awry, again, you get excess inflammation and potential autoimmunity occurring. And I want y'all to take away the fact that these signal transduction pathways are what are primarily seem to be responsible for developing immune deficiency and autoimmunity, and that these affect the way the T cells are functioning, and you end up having a disease process as a consequence of that. So let us begin with a basic question. Why is there immunity? And most people think the textbook example of self versus non-self recognition. And that's kind of true to allow us to see what's self from infectious organisms. But the reality is our immune system developed through time for reproduction. And that's a story for a different day, but I'll be happy to explain what's happened in there and how the immune system got co-opted from reproduction to be utilized for protection against foreign invaders. And so when we think truly how the immune system is working, it works by self-recognition. So the textbooks will always say self versus non-self, but technically it doesn't know non-self, it knows self. And I'll show you why this occurs in a few slides, but the T lymphocytes are raised through the thymus to recognize the self-HLA and self-peptides. And as long as the self-peptides are maintained within a narrow range of activation processes, we have normal immunity and we have normal immune function. It's when it falls outside of those ranges that we end up having autoimmune disease process. And so the beautiful paradigm for this is it makes a lot more sense from parsimonious type of approach is to have something that recognizes self. So it looks for that barcode, it looks for some kind of a signal that should be recognized. And then if it doesn't find that signal, it starts an activation process. And that's how our normal immunity works. And so now, why are we developing autoimmunity if this is so brilliant the way things were arranged? Well, we're making millions of different individual T lymphocytes and B lymphocytes based on their T cell receptors and antibodies that the B lymphocytes are producing. So each would have the capability of finding a foreign antigen. And what we try to do is eliminate or retain the useful ones, then eliminate the useful and the ones that bind too strongly. So the useless ones just take up space and energy, and the ones that bind too strongly to self would result in triggering the autoimmune disease process. And so I've called this the Goldilocks Rule, and we want to keep the ones that are just right, get rid of the useless ones, the ones that bind too tight. And so back to this concept of quality control again, that 95% or more of the T B lymphocytes that are developing in the thymus for T and the bone marrow for B are eliminated because they're useless or harmful. Only a small percentage of those that actually develop have capacity to be useful for us. And so central tolerization occurs in the thymus for T lymphocytes and bone marrow for B lymphocytes, where we undergo a selection process to select against useless ones and to kill off the ones that would be reacting too tightly. And we call that positive and negative selection. I'll describe that further. And so if this works the way we want to, we'll keep the cells that are just right, provide immunity. And so this is just to give a cartoon schematic to recognize that right in the middle here are the HLA molecules, this being a class 2 with an alpha beta chain, and then the TCL receptor below that, and an antigen, the big A in the binding group. But there are numerous co-receptor signaling processes that are with this to allow the immune system to function. And one of them involves IL-2, and I'll briefly use that to help illustrate some of the next things. And so here we have an IL-2 receptor. It's made up of 3 proteins. It interacts with what are known as the JAK proteins that interact further with STAT proteins, and then these translate a signal into the nucleus. And so, for example, if we look at one of the chains of the IL-2 receptor and it binds too tightly, then it could start generating excess signal. But if you have a STAT protein that works less well, then you still end up with a normal signal. Conversely, you could have binding to the receptor be reduced because of polymorphisms, but have increase in the JAK or STAT activation pathways, so that the ultimate signal is normal. But as you can see from that, if someone inherits an abnormally low-acting IL-2 receptor gene and a JAK or STAT gene, then the signal is too low, and you'd end up with immune deficiency. Whereas if you overstimulate this, then you might end up with overactivation and could end up with autoimmunity as a consequence of that. And so we have mutations throughout all these pathways in our body that are polymorphisms, most of which do not create a large effect of things. But as with everything in biological properties, there's basically a bell-shaped curve of where each of these are working. So most of us fall well enough within the bell-shaped curve that we don't end up with any bad things happening with us. But if we have something that's falling at sort of at one end or the other, we are going to be at higher risk to have something go wrong. And so here's an illustration of that positive negative selection that I was mentioning that would be occurring in the thymus. And so the T lymphocyte is going to be binding to HLA molecules that contain self-peptides. And those that can't bind at all to the HLA molecules die from neglect. And that's known as failure to undergo positive selection. Those that bind with varying strengths to HLA and produce varying signal transduction will be effector cells, and then the T regulatory cells, which are there to try to help slow down abnormal immune processes. And then the ones that are binding way too tightly are going to generate so much of a signal that they will be induced to undergo apoptosis to be killed, because those would generate constantly autoimmune disease. And so to think about this in another way, if we've altered the signal transduction that's occurring in there, now we may be maintaining some useless T cells that are wasting energy for us. We may be pushing some effector cells a little bit stronger than they should be. We may have some Tregs get pushed over into much too tightly binding, and it could cause problems. And so all this process where we've altered the signal transduction strength, we can end up with a repertoire that is not going to function in the normal sense that we'd want, and have underactivity or overactivity for things that can then result again in immune deficiency or result in autoimmunity. And the lack of illumination of some of these cells by the central tolerization means that we need something else to help us out, and that's called peripheral tolerization. And so the central was what I just described with positive negative selection, and then peripheral tolerization involves other components. And so not all of those useless and too tight binding ones do get eliminated. Some squeak through, so quality control related issue. Peripheral tolerization are mechanisms to help control things when central tolerization has failed. And so these are primarily anergy, apoptosis, and the T regulatory suppression. And I'll illustrate that. And so here we have different types of T cells reacting with different cell types. And so all of this is going to ultimately involve altered co-receptor signaling. And so if we have a lack of co-receptor signaling down here in the bottom, then that cell will undergo anergy. So in this case, the CD28 did not have its co-receptor signaling. If we have excessive stimulation, so that it's occurring too much, then you activate fast ligand genes to bring about apoptosis of those cells. And then we have the doppelganger cells, the regulatory T cell that has exactly the same T cell receptor as the effector cell, but provides a suppressive activity when it binds the self antigen. B lymphocytes are also important in all this process. And what many people don't recognize is we make a whole new repertoire of B lymphocytes every 2 weeks. And so that's why things like ANAs increase with age, because we're producing more B cells. And if the quality control fails over time, then we still end up with more of those autoimmune provoking B cells. And so things like hemolytic anemia, thrombocytopenia, and so forth that tend to creep up as people get older are partly a consequence of this, being that they are producing B lymphocytes that could cause autoimmunity that we're not able to eliminate. But it's now very clear that B lymphocytes play a very immunostimulatory role. So they're one of our major antigen-presenting cells. And that's why medications like rituximab are useful in things like rheumatoid arthritis, because it shuts off the antigen presentation. And so just the same concept with B lymphocytes, again, not going to belabor it, but multiple co-receptor signaling pathways to bring about the correct signal strength. And that if changing the threshold of that is going to alter the types of B lymphocytes that are being selected for. And so Here again, the same type of concept. Under normal circumstances with normal threshold of signal strength, normal signaling, you get useful effector B cells and you kill off the B lymphocytes that would be producing autoantibodies. But if you change the signal transduction, then now you're retaining B lymphocytes, more B lymphocytes that could cause problems. Lymphocytes then put autoimmunity by autoantibody production, by presentation and stimulation of T lymphocytes, and therefore again a target for rituximab, which can help stop that reactivation process from occurring. So we've been talking about parts of normal immunity that are what sometimes is called adaptive, because T cells and B cells form their own specific receptors. And so overall, the central tolerization and peripheral tolerization work well, but an infection, chemicals, other factors that we mentioned before may overstimulate or resurrect cells that had been otherwise been put into an energy type state. And then again, you can end up with autoimmunity occurring. And so we end up having further counter-regulation processes to try to control the immune system. And so when Dr. Clothier and others talk about cytokines, they are activating, but they're also counter-regulating. And I'll show you that in a moment. And just to give an example of things, the Th1, Th17 type Tifilons promote inflammatory autoimmunity, such conditions like psoriasis, rheumatoid arthritis. They're promoting graft rejection for transplants and graft versus disease and so forth. And so here's a paradigm to try to look through that. Obviously, it's sort of complicated, but let me step you through it here. So we start with a thymic immigrant that's a naive cell, and that naive cell, under stimulation of IL-12, IL-8, will become a Th1 for intracellular protection, so against viruses or intracellular parasites. Under the influence of IL-4, it will become a Th2 to provide us antiparasitic immunity as well as B-cell help for production of antibodies. And inherently, the Th1 are inflammatory, and inherently, the Th2 are anti-inflammatory. And I'll show you that further in a moment. They counter-regulate each other. And that counter-regulation is there to try to control excessive inflammation. Th17 occur under the influence of TGF-beta and IL-6 and also promote autoimmunity, but these fight off extracellular bacteria and fungi. And so if you are missing these cells, you tend to get a lot of fungal infections. Then our next is the T regulatory cell, and the naive cell under the influence of TGF-beta will produce a T regulatory cell, and these are there to try to downregulate the active inflammatory T lymphocytes. But you don't want to downregulate them till the infection is over, so the Th17 produce cytokines to prevent the Tregs from activating up until the infection is cleared. So when the Th17 start dying down, then the Tregs can sort of come in to really mop up and greatly reduce the inflammatory process. And so some interesting things about our immune system is that we're actually programmed towards Th2 and parasite protection, antibody production. And if you think evolutionarily, that makes sense because the mother is putting things in the baby's mouth and it's not being cooked or sterilized otherwise, and they're going to get parasites. And so this is what's useful towards protecting the mother and the fetus from the mother from rejecting the baby and the baby from trying to reject the fetus. And so we come out with strong Th2, and that's why allergies can be such a problem in individuals. But when you drive Th2 response to the extreme, you end up with diseases like lupus or dermatomyositis. And then we have the Th1, which is sometimes just called cell-mediated immunity, or you might have heard of this type 4 immunity, or DTH. And this provides protection against the intracellular pathogens. And when this is overactive, especially in conjunction with Th17, you end up with autoimmunity problems such as rheumatoid arthritis, graft rejection, and the rashes you see with conditions like psoriasis. Th17 are also cell-mediated type of immunity, but these are for extracellular organisms. And so their activity are there to protect us from fungi and bacteria, but if they're driven to the extreme, usually with help from Th1s, again, we start pushing towards the inflammatory disease processes. The T regulatory cells are noted because of their production of IL-10, which is an anti-inflammatory cytokine, and TGF-beta, which is another major anti-inflammatory cytokine, and that they express FOXP3 in their cell cytoplasm and nucleus. And these are there to downregulate and help to induce tolerance. And so we have these counter-regulation processes because we're trying to create a balance or homeostasis between excess inflammation and protection against invading organisms. And so to illustrate this, if the Th2 have become activated up, Th1 produces gamma interferon to turn off the Th2. And conversely, if the Th1 have been activated up, the Th2 produce IL-4, IL-10 to turn off the Th1. And then the Tregs are producing TGF-beta and IL-10 to try to shut down the Th17 Th1s, again, trying to prevent excess inflammation. And so this counterbalancing is very important during all of our normal immune processes as we're trying to fight infection off and trying to prevent us from damaging our tissues. And as an aside, we don't know how to, our immune system doesn't know how to deal with COVID, and so we get excess inflammation as a consequence of it, and that's why a lot of the problems occur. And that's something that if anybody wants to ask about, we can discuss later. And so finally, the Th17 try to keep the Tregs from activating until the infection is cleared. So you try to maintain a balance to maintain this healthy state where there's not excess inflammation to cause problems. And we're already mentioning about the quality control failure. And so if you have antibodies or T lymphocytes that bind too tightly and we're not eliminated, then these can result in autoimmunity. The quality control failure that we're discussing is, again, probably the major reason that we have cells sitting there that are ready to be activated up to cause autoimmunity, when otherwise our immune system may appear to be working quite normally. And so these cells are persisting, but they should have been eliminated. And once again, mutations in signal transduction and regulatory pathways are playing a major role in all of this. And when we think about this quality control issue and we think about immune deficiency, that we're making millions of different antibodies and individual T lymphocytes. But if we have an impairment in our normal immunity, then we'll have a fewer in our repertoire to choose from. And so what can happen is our immune system wants to survive from infection, even at a risk for autoimmunity, and hang on to more of these cells that have autoimmune potential so that we can keep the repertoire more full. And as we've already mentioned earlier, that something has to trigger the autoimmune process. So by and large, most of those cells aren't going to ever be triggered to result in disease. But when they do, you have people that have very unusual and complicated situations because they're having autoimmune disease in the midst of having immune deficiency. So again, to compensate for this underproduction, that we might retain some of those that are useless or too tight binding. And once again, would result in autoimmune disease. So a summary of the adaptive part of the immune system, then we'll go over some data that I think you guys would find interesting, that our normal immune system develops a repertoire which can occur with useless and potentially autoreactive ones that we try to eliminate. And there are control methods that are there to try to prevent this, so we can prevent autoimmunity. And these are there both in the central context as well as the peripheral context, and also counter-regulatory processes from the cells that are active in the periphery. But the genes that one's inherited and environmental factors, from primarily viruses, but other infectious organisms can do it, and chemicals may do it, radiation can do it, and these can allow these autoreactive T lymphocytes that had been adrenergic or under control to be brought out of their energy and now result in autoimmune disease. And as we've already mentioned, that certain HLA components make one have higher risk for development of specific autoimmune disease processes. Patients with immune dysfunction may be even higher risk for developing autoimmune type of problems because they try to preserve some of these potentially autoreactive T lymphocytes so they can maintain some level of immunity. And so we have a quality control failure again. And the genes that might be reporting immune deficiency, because of the alterations in the signal transduction pathway, may result also in the inability to control the T lymphocytes, B lymphocytes have developed, again, resulting in cells that are autoreactive. And so all these processes are trying to work to help control this excess. And so trying to balance the cytokines out. But there can be problems if you're deficient in some of these pathways. You don't get the balancing effect that you need. And so let's move forward again. And so we've been talking about the part that most people have been trying to study for the last 40 years after T cell receptor was discovered, to try to understand better the specificity that's arising out of the immune system. And what's becoming more clear is that we really have a hard time finding the specific antigens that are causing disease. Some I mentioned earlier, but there are just a handful that we can identify that are truly the inducing agent for specific autoimmune disease. And so what we have to remember is that before the T and B lymphocytes are becoming involved, there's something occurring in the tissues. There's tissue injury. This can be physical injury or infection. The cells that are injured then send out recruitment signals. Many of these are called chemokines, and I'll describe those in a moment. And so all of these are, the recruitment will be recruiting white blood cells, and typically neutrophils are the first to show up, and they're there to try to engulf any microorganisms that might be present. Soon macrophages are there, and the macrophages are picking up the damage and looking at the damage. They're phagocytosing debris, microorganisms, and cells that are present, trying to clean up the damage that's there. And all these are going to be presented in that individual's HLA, and then the macrophages are sending out further signals to try to get the T lymphocytes that could respond more specifically. So a specific type of streptococcal infection, get the specific T lymphocytes there that can deal with that. So here's a slide to just help you understand that these processes are occurring in the brain in addition. And I'm going to move into this upper slide here a second to sort of help illustrate. So you have the white blood cells that are happily migrating through the capillaries and small venules. And if there's been an injury of some form, then there are chemokines and chemokine receptors that are present that are telling the white blood cells to come check out this injury. And so over here sort of illustrated that concept. You have the injury, you send out the chemokines, and the cells come in to try to check out what's going on. And so chemokines comes from the name chemoattractant cytokines, so that's shortened to call chemokines. And the cytokines are primarily involved specifically with T and B lymphocyte development proliferation. Chemokines primarily attract cells to the area, and most of the time they're attracting monocytes, neutrophils, eosinophils, basophils, but they can also attract B lymphocytes and T lymphocytes. They're produced by multiple cell types, and they create basically a chemical gradient that cells can follow. And so cells that are being attracted there follow to determine where the strongest chemical signal is to accumulate in the area where the damage is occurring. They can induce inflammation. Some of them are induce homeostasis, and some play roles in both of those activities. So let me tell you about a young man, about 20-year-old, who presented with severe depression and obsessive compulsive disorder. And amongst his complaints were mental fog and fatigue. And you heard Dr. Clothier mention that in regard to COVID. And an evaluation was performed to try to look to see if there's more going on. And autoimmune neurologic evaluation revealed they had anti-tubulin antibodies and anti-CAM2 kinase antibodies. They were quite high. The people performing those assays said those had been a couple of the highest antibodies they'd ever seen in their studies. CSF and blood was obtained, and methotrexate was begun, 10 milligrams a week with folic acid each day except the day of methotrexate. After 6 months, blood was obtained once again, and there had been obvious clinical improvement. The mental fog had greatly lifted, fatigue had improved, and the depression had basically resolved, and the obsessive compulsive component, while present to some extent, was controllable. And so we analyzed 54 different cytokines, chemokines, growth factors, and immune modulators to see if we could learn something from this patient. And so here we're looking at chemokines. And the one called Rantes is very high and had a 50% reduction. The one called eotaxin was elevated or was in normal range for age, but had a large reduction. Another one that's important is MCP1. And to tell you, to explain what we're looking at, the green is CSF, and we only have prior to treatment CSF. We don't have post-treatment CSF. The yellow is prior treatment blood, and the gray is post-treatment blood. And so the fall off between the yellow and gray is an indicator of reduction in those specific factors. MCP1 is interesting because it's elevated in the CSF compared to the blood. IP1 is also at a similar level in the CSF as is in the blood, whereas most of the other ones are not quite high in the CSF. Our final one, a final couple that are elevated was the MIP3 beta and IL-8. And IL-8 is elevated above its normal limits in the CSF. IL-8 is what attracts neutrophils to an area. So let's look at some more here. And so these are growth factors that are utilized to promote vascular growth, cell growth. And for the most part, we see a similar process where the different cytokines involved have a reduction in their amount in the post-treatment. It's interesting that, for example, IL-3 is a major cytokine in the bone marrow for helping the bone marrow to maintain its growth and production of cells, and it's not involved with this. And so there's information that we need to learn about what all this ultimately means. Here are some of the factors that are involved in immune regulation. You can see, as noted before, that we have a couple of them that were slightly were higher in the blood before treatment and then lower after treatment. But we have one IL-1 receptor antagonist that is quite elevated in the blood compared to normals, but it goes up after treatment's begun. So perhaps it's trying to help control the inflammation further and all. The increase is not much, it's only a 6% change. So once again, we need more study to determine the full meaning of these. And here are some of the classic cytokines that people will talk about. The main ones on the left-hand side are involved in Th1, Th17 type activation. The main ones on the right-hand side here, the IL-4 to 33, are involved in Th2 type activation. And what's interesting is even though Rantes and eotaxin were elevated, IL-5 is not elevated. And most of the other Th2 type did not show much change. The only one was IL-10, which is one of our major counter-regulatory anti-inflammatory cytokines. The interferons showed no difference in the CSF, blood, or post-treatment. And so the interferons would be there at the start of an infection. And so this is suggesting that whatever was occurring at the time we were testing it was not part of an acute infection. And what's interesting is after treatment, we have IL-12, which is, I noted to you, helps push the Th1 pathway, IL-17 involved in the Th17 pathway, and then the IL-1 receptor antagonist, which tries to downregulate these processes, or what are increased after treatment occurs. And so it looks like perhaps IL-1 receptor antagonist may be a useful marker for identifying people that are having increased inflammation. We know that from studies looking at rheumatoid arthritis, and also in this setting of like this, where there may be neuroinflammation occurring. So even though the IL-1 receptor antagonist is not elevated in the CSF, it may be trying to calm down the immunity in the body to try to bring things under better control. And so just wanted to show you those more specifically. And the MCP1, you can see in the CSF was not elevated, but was elevated in the blood at the beginning and after treatment. The IL-8 was not very elevated in the CSF and jumped up, and it was above the normal range when we look at it in the blood, and dropped down to within the normal range after treatment was begun. MCP1, whoops. I'm sorry, I couldn't read the slide here. I told you those numbers wrong. Let's see if I can move this out of the way. Okay, I apologize. The upper left hand is IL-1 receptor antagonist, and you can see that it was not very elevated in the CSF, was elevated quite high in the blood, and went up higher after treatment. Rantes is the other one that was seemed to be high, quite high in the blood, and went down to normal range. MCP1 was already present in the CSF, which is above what would be expected in normal CSF, and went down, was lower in the bloodstream, but still in the range of values, but dropped down to the below the normal range after treatment. And so again, MCP1, monocyte chemotactic protein, so a very important chemokine for pulling monocytes to an area. And then finally, the IL-8, where it was greatly elevated in the CSF compared to the blood, and dropped down, was not very high in the blood, but dropped a little bit further after treatment. And so let's see. Oops. There we go. Well, the fun part isn't showing up very well on the Zoom call, but I'm calling this spoilers because of of the fact that I'm going to talk a little bit of what's going on further with neuroinflammation. And so there's a lot going on with neuroinflammation with cytokines and chemokines. I'm going to just narrow this down to the inflammatory area, and want you to note that we have MCP1 rantes as some of the major chemokines involved in microglia activation, astrocyte activation, and lymphocyte activation for causing inflammatory disease in the brain. And let's see, there we go. And so here's just a slide that to illustrate there's a lot of crosstalk when inflammation is occurring with chemokines, with the various cell types of microglia and astrocytes, and even the neurons. And it turns out that all of these cell types have chemokine receptors present on them. So they're susceptible to the inflammatory or the homeostatic function that would be produced by the correct form of chemokine. And so just to further leave you with some thoughts, that chemokines are felt to play a major role in neuroinflammation, some of which may be beneficial and some of which may be detrimental. MCP and rantes are mediators of acute and chronic inflammation, as I was pointing those two out to you. And rantes seems to have a potential protective role in Alzheimer's disease. And so when you read the articles, certain levels of rantes at certain stages of disease may be creating more problems. And then as you go further in disease, it may be helping reduce the inflammation that's occurring in the brain, perhaps by stimulating the correct types of monocytes for clearing up debris and material that is accumulating in the brains of Alzheimer's. Then finally, I want to point out IL-8 concentrations in cerebral spinal fluid patients with unipolar depression. Our patient who came in with a major form of depression had elevated IL-8 in his CSF. COVID-19. So just a couple of quick slides. And I need to orient you on here. Group 1 are patients that are hospitalized. And so these are very sick patients with COVID. Group 2 are patients that tested positive, but at the time the blood was obtained, were not very ill, did not require hospitalization. Group 3 are patients that are some 3 months or more after their severe COVID. Group 4 are controls that had not tested positive for COVID. Wanted to note that Rantes is staying up after the infection is cleared. IL-1 alpha, which is the it's a cytokine IL-1 receptor antagonist block, is staying up after the infection is cleared. Gramzyme B, which is produced by monocytes and NK cells to kill cells, is remaining up after the infection clears. And the IL-1 receptor antagonist has gone up after the infection has cleared, presumably trying to help downregulate the inflammatory processes that are present there. So several cytokines and chemokines, in particular chemokines, are involved in neuroinflammation. And they may be associated with psychiatric disorders, as we were noting from some of the different references. Anti-inflammatory therapy appears to improve the level of inflammatory cytokines, chemokines, at least in a patient in an N of 1, with improvement in mental fog, fatigue, and psychiatric disease. Patients post-COVID have evidence of continued inflammation with the most complaints of mental fog and fatigue. And we've looked at their blood, but we haven't got any CSF from them yet. We need more studies to determine the roles of these and to help sort out which are going to be the meaningful ones for diagnostic purposes, but also the meaningful ones for trying to inhibit or help reduce what's going on. So, for example, methotrexate seems to be working quite well, but it has its downsides in addition, and may not be ultimately the best therapeutic intervention to occur, but it may be possible that giving anakinra, which is IL-1 receptor antagonist, would be the correct therapy to use in a patient like the one that I discussed. Thank you for your attention. As I said at the beginning, things are always more complex than we want them to be, but hopefully I haven't made it too overly complex for you to have felt that you've learned something today.
Thank you, Dr. Harville. So we have time for some questions. Dr. Clothier can start off with a couple of questions to get the conversation going. And then if anyone else has questions, please let me know. I'll call upon you to ask.
Yeah, I'm gonna just boil it down and say, okay, Dr. Harville, we have a patient whose psychiatric condition has markedly changed after COVID. How should we work them up? I mean, what should we do to try to, identify whether or not there's an autoimmune encephalopathy?
Yeah, I wish I had the simple answer for that. At some point, I think we need to be looking at CSF as well as blood, and looking at some of the major chemokines that are involved, so like the Rantes MCP1, the MIP3 beta, that we'll probably eventually want to be utilizing these as markers. What we need to do is collect enough data to know how these fall, what categories these fall into, so that we can stratify patients according to their clinical presentations, other phenomena that may be occurring with them, as well as their neuropsychiatric component, and see if we can categorize them in a manner where it predicted certain cytokines, chemokines will be involved, so that we can then progress towards that. Now, in the meantime, we just have a publication that came out a couple of weeks ago that was dealing with autoimmune antibodies that arise from COVID, and it's a complex scenario. But let me see if I can take you all through it. If we have the RBD of the spike protein, we make an antibody against it, that would then prevent that virus from being able to bind to ACE2 that would be where it would enter into the cell. Well, that antibody that is made is sort of an image of ACE2 because the spike protein would bind to ACE2 or could bind to the antibody. The way our immune system works for its regulation control is when we make a new antibody, which will be a new protein in our body that we haven't been dealing with before, we make an antibody against it. And so what we're able to demonstrate is in patients post-COVID that they have developed anti-ACE2 antibodies. ACE2 has a major role in regulation of inflammation. And so in the angiotensin-renin system. And so so we're getting off track here a little bit, but if we can change the infection part of the immunity. So when the infection occurs, the antigen-presenting cell picks up a little bit of the infected material, but most of what is being presented in the antigen-presenting cell is actually self-material. If you cheat and put an mRNA into that antigen-presenting cell and turn it on to produce a lot of specific protein, now the antigen-presenting cell is covered in that specific protein. And so if you can take and give a vaccine to somebody and cause it to overstimulate the RBD components, that process being overstimulated, the immune system is going to read as risk for autoimmunity because of the ACE2 production and shut it down. That's why antibodies against the vaccine lasts only 6 months or so. Half-life of IgG is about a month. And so a good immune response will shut that process down, type of a thing. So one way to deal with the patients may be to immunize them multiple times after they've had COVID to try to redirect the immune system back towards being specific for those COVID components rather than the myriad of components that were present in the original COVID viral particle.
Would the IL-2 RA
yeah.
be a reasonable test?
It's going to tell you that there's increased inflammation or not.
Okay.
Okay. And so if you're, so that's why I like that from what our data are showing. And it can be independent of like a SED rate or CRP.
Mm-hmm.
And so you end up with a patient where the SED rate is not particularly elevated or CRP is not elevated, and you're thinking they don't have a lot of inflammation occurring, but the IL-1 receptor antagonist being elevated indicates there really is.
And are there ways to target the Th17 in cases where you think there's an autoimmune encephalopathy?
Yes, there are monoclonal antibodies that can be utilized for that. That would help with both the Th1 and the Th17. And one of the dilemmas with these monoclonals, though, is that one of the rare side effects is the ventricular leukomalacia. And so when you're dealing with somebody that already has problem occurring in the brain, where there may be excess inflammation there, that the monoclonals may not be the best approach. And so what would be probably a better approach would be the JAK inhibitors, where you're not going to see that same process occur. Now, that said, the JAK inhibitors just this past week got a new black box warning on there, but those primarily involve the JAK1, JAK3, and some of them are JAK1, JAK2, and there's even one that's just primarily JAK1. And using that very specific inhibition may allow you to not create a worse setting, but actually bring about some benefit.
So with the folks that do have like a post-COVID autoimmune encephalopathy, do you think they're going to require lifelong treatment?
No, I don't. Well, if somebody had started without any problems, so did not have any autoimmune disease, apparent autoimmune disease, did not have any apparent neuropsychiatric type disorder, and has developed the post-COVID neuropsychiatric components, I think they have a good chance of that resolving based with time, therapy, and immunization. Someone that came in with underlying neuropsychiatric disease may not. It may need to be lifelong because they may be triggering and maintaining that scratch that keeps the inflammation going.
Well, I appreciate your presentation. It is an area that is a little foreign to most of us, but I think it's going to be something we're going to need to become more conversant about in the future.
Thank you very much. And I'm available for other questions, or somebody wants to email me or has a specific question that they didn't want to present in the group. I'll be happy to talk to them about it.
Thank you, and thanks for agreeing to give grand rounds. Let's everyone give our speaker a round of applause.
Thank you.